Now, I have to make a disclosure. I have a consultancy company, and part of my consultancy is also done for Vitrolife. You already have seen that IVF procedure chain is actually a mix between the clinicians, the patients, the embryologists in the laboratory, and of course, again, the clinicians and the patients. And we travel through this journey also during our talks which we have here. I think most of you should be aware of the fact that in the laboratory, we have the hugest number of variables, I would say. We have more than 200 variables which can change, which we need to control in order at the end to have a good outcome, which is live birth. Because if we have any effects here in the laboratory on these variables, it can affect everything from pregnancy rate up to the health of the baby. So I will go through these graphs with you and through this talk by focusing a little bit more on the basics. And Simon actually later on will take up what I call the technology. But whatever technology you use, you have to have the basics proper, otherwise the technology will not work in your hand. So I think it's very important to focus on few of these aspects here, which are divided in the chain, how actually the embryo travels through the laboratory, and how we have the different aspects which are important within our laboratory work and beyond. Oocyte retrieval. I like to challenge you that this is not only a pickup, it's actually more than that. It starts already the day before when you prepare your dishes, because you have to take certain things into account, otherwise you can make a mistake and set something bad already the day before you even start. We have a lot of parameters to control, and I will come back to these several times during my talk because I think they are extremely crucial. Dish preparation. Very nice paper here published by Jason Swain a couple of years back. Some of you may know it, but the bottom line message of that is if you don't make your dishes properly, if you don't control and be aware about temperature, evaporation, droplet size, that affects finally osmolality, you can actually make dishes which have droplets which are in around this range of osmolarity, and that will have a dramatic impact on whatever you do. And you are not aware of that, you simply put the oocyte in and the whole thing is already gone. I think that's something very, very crucial to be aware of. Then this one here. I do a lot of consultancy work, and that is one of the major things I focus on, temperature. If you look here on the pickup process during follicle puncture, there is actually a nice paper measuring temperature and all these different points. And what you can see is depending on how good you are to keep your embryos warm once they come into the tube, you can see huge differences. I very often see people holding it in the hand during the puncture. The hand is not 37 degrees, and that's what happens. The temperature drops down to something like 28 to 30 degrees. And that may have an impact already on your oocyte because oocytes are quite sensitive. Same for heated stages. We then isolate the oocytes on a heated stage. Have you ever looked on the diversity of temperature on your heated stage? You should measure it. It's tremendous between one point on the other. So we usually have a mark on those spots where we know that they are always quite well working. And then you have these nice dishes. These are standard culture dishes, and you can see a temperature profile. That's a heat map for this. You can see that only one dish here at this heated plate, which is around 37 degrees, comes close to something like 36, 36.5. All the other dishes are much colder. That's challenging, that's thrilling actually, and I think it's frightening. So you have to use proper dishes. There are certain dishes on the market where you definitely can see that they transfer the temperature like it is from the plate to the dish and to the culture medium. And the bottom line message of that is measure. You have to measure, not the plate, you have to measure actually a droplet where you actually keep your oocytes in. On the next slide you actually will see a video. Just follow that firstly because it doesn't repeat. You saw here a spindle in a human oocyte and the spindle disappeared, and you have a mouse oocyte beside and you can see the spindle is still there. There's a huge difference between these two, how they react, so that's why I don't like to take one for making certain assumptions and extrapolate that on the other. But the bottom line of this slide is more or less that if your oocyte is exposed to certain bad conditions, like for example a drop in temperature more than 5 minutes at 28 degrees, the spindle is gone. 100% of the spindles in all oocytes are gone. The same if you have a shift in pH and you use unbuffered medium for 8 minutes, the spindle has disappeared. The bad thing is it will not recover in all of the oocytes to 100%. You may have had an artificial aneuploidy at that time point already. Going to culture, you can see that some of the things are repeated, like temperature, pH, but we also have handling oxygen, media formulations. Already an incubator opening on day 2 can affect the development of your embryos. Opening the incubator, taking the dish out, placing the dish back, that's what you can see. With the study having day 2 observation or not, door opening or not, you can see an effect on the quality of the embryos on day 3, but also on the conversion rate to the blastocyst stage later on. Temperature stability is crucial in incubators. I just have here 2 comparisons. That is a benchtop, conventional benchtop. You see an effect of a door opening for 5 minutes. It's quite a small drop, but still the effect is there for a longer time. If you go to an optimized benchtop heating system like we have in the embryoscope, door opening has no effect at all on the temperature. This is a study which was actually published a couple of years back, where we looked on temperature and the effect on embryo development. And if you have a constant temperature at 36 degrees compared to 37 degrees, you get definitely an impact on your usable blastocysts at the end and also on your pregnancy rates. That is constant 36 degrees, but if you have fluctuations, you will see similar effects, maybe not to the same extent, but you will see the effects. They are there. Gas recovery, that's my favorite. I mean, we all more or less rely a little bit what our incubator tells us. That's what the incubator tells you after a door opening. That's the display of the CO2, and you can see that the CO2, according to the incubator, is recovered within 2 to 3 minutes. But if you make an external measurement, it takes much longer. It's about 15 minutes where the CO2 needs to come back to normal. That's a standard-sized incubator. Most of us still use them. Again, optimized benchtop, where you can see a door opening. Within 2 minutes, CO2 and O2 is actually recovered to normal. So this is actually where we want to go to. We want to have a reduction of these effects as much as possible. You see the slide here again, because what is important for pH at the oocyte stage, of course, is also important during culture. Maybe you know that the pH in the oocyte is pretty more difficult because the oocyte cannot regulate the inner pH. It can only adjust to what is outside. The embryo has a much better regulation capacity. But does it mean that you can throw the embryo in everything? Definitely not, because the more the embryo has to adjust the pH, the more the embryo undergoes stress. And this stress can accumulate, of course, so it's a stress factor, definitely. And I think never everybody looked on the spindles in embryos, whether they also disappear or not if we don't treat them nice. So you have to know your optimal pH. What is the optimal pH? Ask your company, because usually the leaflets come with 7.2 to 7.4, but that's not necessarily optimal. They may grow, but there are differences, especially if you do not want to stress them. Nice example here, which I always like to bring up. Most people don't know that the CO2 is really dependent on where you are. And it makes a difference whether you are, let's say, in Istanbul or Helsinki, where you have actually sea level, or whether you are in Lhasa in Tibet at an altitude of 3,560 meters. There is an embryoscope in this city, and this is running at 11% CO2 in order to have a proper pH in your culture medium. Denver, David worked there, is around 8%, 7%, something like that. So you should really be able to measure your pH. CO2 is quite nice to measure, and it's quite nice what it shows, but measure it so that you really can prove what's going on. Low oxygen. Interesting, because you have a lot of talks here, and even coming talks like debates, is low oxygen beneficial or not? I think this answer is a no mind. It's quite clear that actually we need low oxygen in our culture. Most people think you only need it for day 5. Definitely you need it also for day 3 culture already. There is a lot of literature on that. You have a lot of compromises. And if you culture at atmospheric O2, you can actually induce, again, a lot of oxidative stress, which you can pick up in the epigenome, in the transcriptome, in the proteome, viability, and long-term development. So try to avoid that. Give the embryo the best, which is low oxygen. It may result, as shown, in higher implantation rates and live birth rates. Reprotoxicity, a new word. Maybe some of you have not even heard it, but I like it because it brings to the point what we can see very often. We can actually introduce toxicity during reproductive treatment, and it may have an effect later on. We can see it on the fertilization rate, implantation rate, live birth rate. This is a study by Martinez published in 2009. 42% of our items which were in contact with the patient in IVF actually were reprotoxic. And if you looked on those which had contact to gametes and embryos, 10% of these items were reprotoxics. That's really frightening, because you should try to avoid it. And you should try, or you should understand that you can find this reprotoxicity sometimes even between lots of the same product, lot-to-lot differences. So when you open one batch and you open another one, or you open one package of dishes and another one, it may change. There might be a difference in terms of that. This is a slide which I really find interesting and again frustrating. 25% of all IVF plasticware failed a mouse embryo assay. David published that. This mouse embryo assay actually went a bit more further because it also counted cell numbers and trophectoderm and inner cell mass cells. But this here is interesting. 60% of the raw oil which is used in order to produce oil for our culture fails mouse embryo assays. Imagine that. And those of you who are longer in the field, maybe you remember the times of embryo males in 2000 to 2010. We had almost every year a report about toxicity of oils, and we had a lot of discussion about that. You can avoid reprotoxicity by using proper wear, proper lab wear, which is tested for that. And this is just an example of 3 clinics where they compared conventional or IVF-approved plasticware, and they compared those which had been high-quality mouse embryo assay tested. And simply by moving from one dish to another type of dish, they got all an improvement in the clinical pregnancy rate. That's very easy. I mean, you are fighting sometimes very hard to get 5%, which is quite, I think, illustrative and interesting. Air quality, very often neglected. We have volatile organic compounds, and I must tell you that's ourselves bringing that into the laboratory, because we take all these plastic dishes, we move everything into the laboratory, and when we take it out, we wrap it very closely sometimes. This is where the VOCs accumulate, and there are measurements showing that even in incubators you can have extremely high VOC concentrations. So what to do about that? First of all, try to measure it, try to get rid of it. And either you have air quality filtration by having this in your whole laboratory, or you use incubators that have actually VOC filters built in. Some of them are on the market. This is a measurement which was given to me by MTG, which is 4 laboratories. And we can see the VOC measurement shows that these 4 laboratories are very different. Only the green one has really a very good air conditioning system and air system, because they are very low in the VOC levels. But look on the blue ones. I do not want to work in such a lab, because VOCs, of course, then also are coming up to me and on our embryos. If you want to go further on that, quality control is essential. I like this study here, which was actually published by Dean Morbeck's group, where they used time-lapse with an embryoscope in order to show that they could pick up reprotoxicity, which a mouse embryo assay did not pick up, by looking on early morphokinetic markers. So I guess that time-lapse is a little bit a game changer there, because it brings us a perfect way of looking for standardized and consistent data, which I think is the base if you want to do quality control at a very early level and not wait until you see a lot of negative pregnancy outcomes. Infrastructure. It is more than just having an IVF lab. Infrastructure is very important, and I'm traveling a lot to labs. I can see huge variations, and this is actually a little bit a kind of bottom line message of that. You should be able to look on all these variables, and you should be able to follow that and more or less try to make your laboratory a thing which is evolving over time and getting better and better. Proper cleaning. I still see a lot of places where we use alcohol during the normal working hours, which is not good. I think you should replace it with something else. You should be really looking that you have different storage places and not store all your plastic material in a place where you can actually accumulate all that stuff. This may look a little bit confusing to you, but that is how my laboratory worked. So we tried really to track and verify everything what we did, because this is also part of quality control, and this is something which later on pays off if you try to find errors which may actually influence your outcome. So we could trace everything from a patient, from a woman and the man, up to the time of transfer. This is what we did in the laboratory. That's more or less a kind of nice landscape plan about every dish, at what time the dish did what and who did it at that time. I think it's crucial that you go into having systems like that that help you in your daily workflow. Human resources. Definitely, I think, a neglected entity. And I'm an embryologist, and of course I take the position of an embryologist. We need sufficient staff number, definitely. Because embryology today is not only growing embryos and preparing sperm, it's a lot about safety, quality care, data. Data assembly, but also data evaluation. So we need to have more with in-house in order to be able to work with that. But you have not only to stop there by hiring embryologists. You have to make sure that they have a continuous learning and education. It pays off at the end in your results. In-house training is quite good, but also supervision or sending people outside to other labs, just see them differences so that they come home motivated and know that maybe to change. Standardization. That I think is one of the things which time-lapse brought us about, that standardization is something we definitely need to talk about. I just show you this slide. We actually asked, or I asked about 100 embryologists to choose among a cohort of 8 embryos the best embryo. That's what they did. There is no agreement at all. Quite a lot of them were very, very experienced embryologists. And you can see really it goes all over. So I think we need standardization because this choice here definitely has an influence on what comes out after the transfer. So we need to have standardization, and at the moment I think there is no better way than following certain algorithms. We have a nice publication coming up about a day 3 algorithm. There is a day 5 algorithm which is now published for time-lapse, which is amazing because it can give you in the highest core groups up to 70% pregnancy rates or implantation rates. So I think we are really moving forward because we try to get everything in the lab done in a perfect way. And that starts not only by the work we do, but also on all the equipment and everything we have around that. This is more or less a kind of summary, and I borrowed that slide again from David. This is a holistic view, and you can see all the steps which are involved in our laboratory procedures, but also the interaction which is on the patient side, the physician side, and again then later on the transfer side, which is the interaction between clinician, patient, and embryologist. So coming back to this slide which David showed you, we have all these variables, we have all these things which we need to control. All of them are equally important, the laboratory as well as the patient, as well as the clinician. I talked a little bit about the basics, and I guess Simon will talk about the technology which only works once you have the basics in a proper hand. Thank you very much.